Hello, and thank you for joining us for the Smilow shares for colorectal cancer in 2026. This is Colorectal Cancer Awareness Month, and here at the Yale Smilow Cancer Hospital and the Yale Center for GI Cancers, we're going to have a presentation for GI medical oncology, surgical colorectal surgery, radiation oncology, on how we comprehensively care for patients with colorectal cancer. I'll start by introducing each speaker in each presentation and moderating a Q&A session. So again, my name is Michael Cecchini. I'm one of the GI medical oncologists and co-director of the Colorectal Cancer Program and director of GI clinical research. I'd like to introduce my colleague, Dr. Kim Johung, one of the radiation oncologists. I'll let you introduce yourself.
Thanks, Michael. Kim Johung. I treat mostly GI cancers with radiation, and we'll be talking a little bit more about that after Michael's talk.
And Dr. Ann Mongiu from colorectal surgery, who's also one of the co-directors of the Colorectal Cancer Program.
Hi, Anne Mongiu. I'm a colorectal surgeon here at Yale, and my part of the team is to help with surgery to remove the cancer when the time is right.
And so just some housekeeping topics. If you can put your questions into the chat through the Q&A, I will then repeat your questions to the appropriate speaker. And I will be starting off today talking about some of the medical oncology aspects of colorectal cancer surgery. So I am going to share my screen here. Excellent. So I'm going to talk about medical oncology management and personalized treatment for colorectal cancer. And here are my disclosures. I'm going to talk a bit about staging, and then I'm going to talk about how, as medical oncologists, we think about some of the personalized treatments and chemotherapies, targeted therapies, systemic therapies, and even immunotherapies we use for these diseases. So, how do we stage colorectal cancer? The diagnosis is often made by colonoscopy. And then we have the question of whether or not this is localized disease or metastatic disease. This workup will often include some blood tests at first to assess some very straightforward measurements, such as liver function tests, blood counts like hemoglobin, white blood cell count, and as well as a CEA, which is a blood marker that kind of gives us an indication of the presence and of colorectal cancer, and sometimes whether or not that colorectal cancer is worsening or improving to our therapies. We also use a sophisticated test at times called circulating tumor DNA. We typically use this test after surgery to help determine whether or not there's any residual cancer left behind. This is a very detailed test and is a lecture to itself, but it's essentially a test that we can do after a surgery where we kind of find if there's any evidence of DNA fragments of residual cancer floating around in the bloodstream. And we can tell that those DNA fragments apart from normal DNA in our blood. And if they're present, it really suggests that there is residual cancer. And then also, we will always do a CT scan to identify whether or not there's any spread of a cancer, micrometastases, or small areas of metastases. We're looking for any evidence the cancer may have spread to the liver, the abdominal cavity, or the lungs would be the three most common sites. So we're also sometimes doing surgery even when this cancer has spread. And so we call limited spread of the disease oligometastatic disease, typically meaning it's gone to one organ, sometimes even multiple sites in an organ. The definition for this is varied depending on what guideline you follow. But the overall term oligometastatic disease means limited metastatic disease. So despite the cancer having spread, it hasn't spread as much as other instances. And usually with oligometastatic disease, our goal is to address the disease with more than just surgery. So if we think about a colon tumor, the most common colorectal tumor, the most common site that may spread to would be the liver. And once it's spread to the liver or the lung or the abdominal cavity, by definition, it is stage 4 disease. it is broken out of the colon and the lymph nodes in that area and spread to other organs. Whereas a cancer that's only spread to a lymph node but not distantly would be a stage 3 disease, and cancers that have more minorly invaded into the wall of the colon but not spread to any lymph nodes or distantly would be stage 2 disease, and in minimal invasion into the colon wall might be a stage 1 tumor. And so one of the first questions we have as a group in our multidisciplinary tumor boards when we see somebody diagnosed with oligometastatic disease is, does this patient still have a pathway to cure? And we work together to usually use some combination of chemotherapy, radiation, and surgery to maybe completely remove and eliminate all the cancer. And here's an example. So this is a CAT scan, and in this CAT scan, we're looking up from this patient's feet. So if that's the case, this would be the right side of the patient with my cursor. So left side of the screen, right side of the patient. This would be the left side of the patient. This is the back. So you can see the spinal bone, one of the vertebral bones right there, and the chest at the top of the screen. And this patient's laying on their back. We're looking up from their feet, and they're sliced like a loaf of bread. And this is one of those slices. So this big gray area would be the liver, and in it is a tumor there that you can see that I'm running the cursor around right there. So this is an isolated frame of the CAT scan, but this was an isolated disease that was able to be removed by surgery. On the other hand, here's another example. Same orientation, right side, left side, chest, back. But we can see here, this patient's liver unfortunately has numerous cancers, and it's not so much oligometastatic disease that we are optimistic up front that we can get that patient, get all those tumors removed. But perhaps with a combination of chemotherapy and potentially other treatments, we can shrink down those tumors enough to change the scenario there and get that patient to surgery. One of the other things that we know and try and subtype the cancer a bit differently is that there's a difference between tumors that arise on the left side of the colon, which is, again, your right, or the right side of the colon, which would be your left, because this is a diagram of looking straight at somebody's colon. So this would be the start of the colon, as stool follows this path and ultimately ends up in the rectum and then is excreted through the anus. So we've identified as a field that when we find a tumor in the right side of the colon and versus the left side of the colon, and we sequence that cancer to find out what mutations are present in the cancer, or look at different methylation profiles, which are other DNA changes in the tumor, we find that they're very different cancers. And the reason is the tissue, the normal colon, it comes from different embryological origin cells as our bodies are forming. And this leads to just different behaviors of these normal cells that can ultimately develop into cancer. And this helps me as a medical oncologist realize that there are different treatments to use or certain tests to do to identify the nuances that may be present to establish the differences of those tumors. There is also some differences in how these cancers may even spread. So we find that these cancers on the right side tend to be more likely to have a BRAF mutation, which is a targetable mutation, to be more likely to be MSI high, which means immunotherapy may be indicated when the cancer has spread. And whereas the cancers on the left side are less likely to have those mutations, and we can use other targeted therapies for those tumors, such as panitumumab or cetuximab. So from a biological perspective, we think of colon cancer as arising through a process called the adenoma to carcinoma sequence, where we start with a normal intestinal, what we call epithelium, normal intestinal lining. And what can happen over time is polyps form through the disruption of this normal lining, the normal epithelium. And so then you get a small polyp and then a large polyp. And along the way, these cells can start to have some abnormalities and accumulate mutations, which lead these tumor cells to become dysregulated, invasive, and ultimately, if they're invasive, become cancerous cells. And that's essentially how this whole process proceeds, and most tumors are formed. And the typical time frame this takes is on the order of years, which is why we do colonoscopies in every 10 years for patients that are standard risk. Now, for medical oncologists, we do quite extensive tumor profiling to determine what are the best therapies we should be offering our patients. So we do some testing, which is called immunohistochemistry, which means we stain the tumor tissue. I should say we order this testing. Our pathologists do this, but we order immunohistochemistry testing, which means the tissue is stained and it's looked at under a microscope by the pathologist to see the presence or absence of certain proteins. And some examples would be looking for mismatch repair proteins. That's trying to identify whether or not a tumor is MSI high and therefore sensitive to immunotherapy, or maybe looking at HER2, which is a different protein, and there are targeted therapies for that. And we also sequence the DNA of virtually all tumors now, and try and identify whether mutations in KRAS, BRAF, or other alterations are present because we have targeted therapies for these scenarios. And so a biopsy may be used again from a lung biopsy if this cancer is spread to the lung, and then stained for some of these immunohistochemistry tests. We can even do liquid biopsies now. So we don't even need to always biopsy the tumor and sequence the tumor. Sometimes we can just get those little DNA fragments from the blood and sequence those and be confident that there's a KRAS mutation or a KRAS mutation is absent. So it's absolutely standard of care everywhere, and certainly at Yale to be doing all of the testing that's here on this page, testing the DNA, testing the tissue to personalize the treatment and make sure we're offering our patients the most effective therapy. So these are the tests that I advocate that all of my patients should know the results from to make sure that they're getting the most effective therapies. And we need every last detail here to be confident that we're actually giving the right drug to the right patient at the right time. So we need to know the microsatellite status. And for patients that are metastatic, when the tumor is metastasized, most of those tumors are going to be microsatellite stable. So 96% of the time, we find that tumors are microsatellite stable, which means at present, there's not a large role for immunotherapy. But for these 2 to 4% of patients that are diagnosed with microsatellite instability high tumors or MSI high tumors, immunotherapy is the main treatment we're using for these patients, and it's highly effective. So this is a can't miss kind of marker that we need to test all of our patients for. And then we also now need to know about KRAS mutations. Is it present or is it not? What is the KRAS mutation? If it's present, we may have drugs that target that KRAS mutation. If it's absent, that gives me insights about using specific therapies. And then the BRAF V600E mutation, which historically has been a very aggressive mutation, but we have targeted therapies for this, and it's important they're instituted early, and we know that there's great data that backs that up, as well as HER2 status that gives us insights about using HER2 targeted therapies. And lastly, again, the sidedness. I need all 5 of these details for every patient I see, every new patient I see, every established patient I see, to make sure they're getting the right treatment, the right drug for the right patient at the right time. So I encourage my patients to be empowered that this is information that they should be requesting if it's not done for some reason. So we're typically using chemotherapy, FOLFOX, FOLFIRI, FOLFOXIRI sometimes. These are chemotherapies. They're not targeted. We use 5-fluorouracil, which is a drug we deliver through a 5-FU pump over 46 hours. We use oxaliplatin given along with that, or FOLFIRI, 5-fluorouracil with irinotecan. These are the initial chemotherapies we'll start with for most patients. We'll often add on a drug on top of them called either bevacizumab or panitumumab and cetuximab. And what we add in the red here depends on what mutations are present. And also, again, we'll add on a BRAF inhibitor if a BRAF V600E mutation is present. Again, why we need to know all these little details is because we personalize each treatment to each patient to make sure we're being as effective as possible towards the patient. And so I'm going to just show a couple slides about how these drugs work, how targeted drugs work. So if we think about a cancer cell, this would be the membrane or the outside of a cancer cell, and below here would be like the inside, and the nucleus would be like the brain of the cancer cell. Cancer cells, unfortunately, often have a lot of active signaling, and that stimulates growth. So, whereas all these arrows is just kind of like a light switch on or a waterfall on into the brain of the cell, telling it to grow. And when we can shut that process down, we can kill cancer cells. We can certainly slow growth quite effectively. And the idea is to target the cancer cells that have this all activated and spare the normal cells. Whereas chemotherapy is more poison oriented and is not so focused on specific pathways. So we know when a KRAS mutation is present, if we can target it, we can shut down this pathway. And we know that when there's no KRAS mutation present, we can target these receptors with EGFR inhibitors, also cetuximab or panitumumab, um, and that adds to how well patients do, how often the cancer shrinks down, how long patients have their disease controlled. Whereas if there's a mutation present in KRAS, BRAF, we know that targeting these receptors up here is less impactful when we use a drug like bevacizumab, which is why I need to know again whether or not a KRAS mutation or a BRAF mutation is present right away. Now we have drugs that inhibit specific KRAS mutations. So if you have a KRAS G12C, there's FDA-approved drugs that target that. If there's a KRAS G12D mutation, there's numerous clinical trials looking at G12V and so on. So these are targetable mutations with approved drugs and many clinical trials that may be relevant for to know this information. Whereas if there's a BRAF mutation present, we have a BRAF inhibitor called encorafenib and cetuximab. So we want to shut that growth pattern down right at its source, right at the BRAF mutation. And we know the recent approval of these drugs within the last year literally doubled the survival for patients with BRAF mutations. There's similar targeted treatments if there's abnormalities in HER2 on the cell surface, something called tucatinib and trastuzumab. Again, why we need to know the details of personalizing these treatments, as well as in HER2 for HER2 positive colorectal cancer. And then to conclude talking about some of these more targeted based treatments is immunotherapy. So for that 2 to 4% of patients that have metastatic disease but have MSI high tumors, we know that they're highly sensitive to immunotherapy because the tumors have many mutations, and therefore the immune system, with given enough push by our immune therapies, has an easier time recognizing the cancer as foreign and can eliminate it. So this is some results on the left here from our initial trial with immunotherapy, comparing it to chemotherapy for these patients with MSI high colorectal cancer. And we saw that again, as time progressed, more patients on pembrolizumab, an anti-PD-1 inhibitor and immunotherapy, had not had their cancer grow and were alive compared to those that got chemotherapy. The majority of those patients at some point, for example, here at 2 years, had their cancer progress and grow. Whereas on pembrolizumab, roughly half of those patients were still stable. Now with two immune drugs, we're seeing at the 2 year mark here that roughly at 2 years, 70-ish% of patients have not had their cancer progress. So we are literally probably curing more than half of the patients by giving them ipi and nivo, ipilimumab and nivolumab, with MSI high colorectal cancer. A rare subtype, but this is something we can't miss because the results can be so impactful. So in conclusion, we need multidisciplinary care for all patients to determine the optimal care plan, whether or not we can do surgery. We still use our traditional chemotherapies for the majority of patients, but all tumors need testing for microsatellite status, KRAS status, BRAF status, HER2 status, as well as sidedness to make sure we're giving the optimal results. And I think patients should be empowered to know the status of these. And immunotherapy is making some big impacts for patients with MSI high disease. So I'll stop there. If there are questions, I will answer them throughout the presentations, but I'm going to pivot now to Dr. Johung to discuss radiation oncology.
Was muted. Sorry, I'm here now. Thanks, Dr. Cecchini. So I'm going to be talking about, this is a very similar title to Dr. Cecchini's title, a personalized approach to radiation therapy for rectal cancer. So as shown here, there's three main modalities for treatment of rectal cancer represented today actually on our webinar. So this is what Dr. Cecchini does. He delivers the systemic therapies, either chemotherapy or some of the targeted agents or immunotherapy that you heard about. This is Dr. Mongiu's area of expertise, removing your actual tumor. So she's the hero there. And this is what I do, radiation therapy, which is a little more foreign to people. So I thought I would start talking first a little bit about the radiation care path. How does radiation work? And then we'll talk about two different ways we can deliver radiation, when you might be able to avoid radiation, specific scenarios for that. Certain scenarios where you might have an excellent response to the chemo and the radiation and you might not need the surgery. And then I'll touch upon what Dr. Cecchini was mentioning was the oligometastatic state, or when your cancer really has spread but only to limited sites, and where radiation might come into play in that scenario. So a little bit of a short radiobiology lecture, which is basically how does radiation work to kill cancer cells? So radiation therapy really is relying on the use of ionizing radiation directed at cancer cells. It's delivered by these big machines called LINACs, really directing radiation with high precision at your tumor. And what the radiation is doing is causing damage in the DNA of your cancer cells. I like to think of these as kind of like the building blocks of your cancer cells. And so if we use radiation to damage the DNA, when the cells try to divide and multiply, they realize they're damaged and they die off instead. But we think of this as a local therapy because I'm really targeting the tumors that I can see on your scans, whether it's CAT scan or MRI. This is an example of the treatment delivery machine and the treatment delivery room. So the radiation is coming from the head of the LINAC here. We have panels on either side that are really imaging panels that help make sure that your body is in the exact right position for treatment. So we can either do CAT scans or X-ray imaging, really to make sure that you are accurately positioned for treatment on a day-to-day basis. And in order to spare the healthy tissue, the radiation is actually delivered from all angles. So this machine will spin around you. And so if beams are coming from different angles, it's really the intersection point that gets the full dose of radiation, and the tissues that the beams are passing through will get a much lower dose of radiation. And we use this is kind of what it looks like if you were to look up in the head of the machine. So there's these tungsten leaves. They look really big in this picture, but they're actually just a couple of millimeters thick. And what they do is they're going to be moving around during treatment with the shape of that field, matching kind of the shape of your tumor target from that angle. What they also do is they will move in and out of the field during treatment, and that can modulate the intensity of the radiation beam. And that allows us to deposit this dose of radiation in your body that fits kind of a three-dimensional shape that matches the three-dimensional shape of your tumor. So these are just a little bit of the technical aspects of how we are able to safely deliver radiation to your tumor and avoid radiation dose elsewhere in the tissues. A little bit about what it involves to get a course of radiation completed. So obviously there's a consultation process where we meet you and talk to you about the indications for radiation and what you can expect. And then we have all these weird terms, and so I go through them. If you were to embark on a course of radiation, we start with what we call is a simulation, and I would think of that as a planning process. So we're going to get your body in position for treatment, and then we need to scan your tumor region in that position so that we can see where the tumor targets lie when your body's in position for radiation. Most often we place rectal cancer patients prone, so on your belly, for treatment. And what this does is that it allows the healthy bowel to kind of fall forward and away from the treatment area, so we deliver less radiation to the healthy bowel. I like to think of this as a nice massage table pillow where you have the hole for your face here and you're comfortably positioned. After the CT scan process, we work with physicists who are called dosimetrists. What they're doing is they're helping us, angle the beams and devise a computer-based plan to deliver radiation that sort of really tightly fits the tumor targets. There's kind of a physics QA process, and then you embark on treatment, which tends to be daily treatments, and we'll talk about the reason for that shortly. This is just an example of what treatment planning looks like. So we've identified on a slice of a scan kind of the nodal lymph node regions that are at risk, and this is what a plan would look like, showing the distribution of the radiation dose to those lymph node regions, but kind of carving the dose away from what I'm showing up here with the cursor is healthy bowel in the middle of those lymph node regions. I mentioned that radiation is typically delivered on a daily basis, Monday through Fridays. The reason for breaking the radiation dose into these daily smaller doses is that cancer cells have a decreased ability to repair the damage to their DNA from radiation, whereas healthy tissues are more able to repair the damage from the radiation. So we break out the dose into little doses. The healthy tissues are repairing, whereas the cancer cells are less likely to repair. And that's how we get cancer kill over time without wreaking too much havoc on the healthy tissues. So when would radiation be part of your treatment plan for rectal cancer treatment? So Dr. Cecchini mentioned a little bit about the staging of rectal cancer, and like all things for cancer treatment, the determination of when to employ radiation depends on the stage of your tumor. Part of that is how deep the tumor extends into the wall of the rectum. So we usually get involved for the deeper tumors, the T3 category or the T4 category. And then whether or not your tumor has spread to nearby lymph nodes, and we are typically involved if there's evidence of cancer involving the lymph nodes around the rectal area. This is just a couple of graphs to show you what is the benefit of using radiation for rectal cancer. So an example from kind of two classic trials showing you that when we add radiation to surgery, the benefit is what we call local control, or preventing the cancer from being able to grow back. So the cancers are going to recur locally in the pelvis more often if you have surgery alone, but when you add in radiation, we can reduce that likelihood of recurrence. And this is just showing you that if you apply the radiation before or after surgery, it's actually more effective before surgery. And in part, some of that is that we have a target that we can clearly see, and we're not kind of treating the space where the tumor used to be. In those two trials that I mentioned in the previous slide, the radiation was delivered in very different ways. So the first trial was delivering radiation in these 5 larger treatments without chemotherapy. And the second version was delivering radiation in daily doses, Mondays through Fridays over the course of 5.5 weeks. And that's given with a light dose of chemotherapy that kind of synergizes with the radiation. So these are two quite distinct ways of giving radiation. So how do we choose between one or the other? I'll start by saying that in the US, the long course of radiation over 5.5 weeks is more commonly used just by practice patterns. The shorter course of radiation is more commonly used in Europe. But if we look at data comparing the two approaches, so the different colors on these graphs are just patients who either receive the short course of radiation or the longer course, and what is their overall survival after cancer treatment. The bottom line is that in general, survival and rates of local recurrence are the same if you deliver radiation in these two ways. So as a patient, I would say, well, I want the faster way and I don't want a chemo pill, so why don't we just do the 5 treatments and be done with it? So when we get a little more nuanced with it, one of the analyses shows that if you have a cancer that is lower down in the rectum, so quite close to the anus, and a benchmark or a threshold we use is about 5 centimeters from the anus. In that particular population of patients, and maybe Dr. Mongiu can touch upon this, oftentimes the surgery can be more complex. And so in that situation, shrinking the tumor, if you will, with radiation first can lead to more successful surgery and less likelihood that there's residual tumor that may grow back after surgery. So I think that would be one of the instances for sure where we're considering a longer course of radiation rather than the short course. And then this is a really complicated slide just to show you that in a trial that the difference between the two treatment pathways, one of the differences was that some of the patients had the short course radiation and some had the long course radiation. This trial was also looking at other things like having chemo before surgery versus chemo after surgery. We now use the chemo before surgery in most cases because of some studies showing, survival benefits to that. But what I want to point out from this trial is that if it is a way to compare the shorter course and the longer course. And this particular trial involved patients with really much more advanced tumors, meaning the T4s deeper in the rectum, those with N2 disease, so a lot more lymph node involvement, and then these other more technical kind of risk factors that we look at as a team. And in these kind of higher risk patients, when we compare the two arms, the patients that received the shorter course radiation actually had a higher risk of local recurrence in the pelvis at about 10%, versus more like 6% with the longer course. So again, I think if you have a more advanced tumor, we certainly want to be proceeding with the longer course of radiation, for this reason, and this trial is supporting that. So just kind of a summary of that is that we definitely prefer the longer course radiation for tumors that are low, close to the anus, for tumors with these higher risk factors like the T4 tumors or a lot of lymph node involvement. Another scenario would be if we want to really maximize local control because we're thinking about maybe trying to avoid surgery, and I'll talk about that in the next few slides. But that the short course we can consider for patients who have less advanced tumors that are not getting close to kind of the edge of where Dr. Mongiu would be cutting for surgery, and tumors that are not really low in the rectum. And so we use this for select patients, but I think really default more to the longer course radiation with the chemo pill. How else can we individualize treatment and the use of radiation? So we know that rectal surgery obviously is going to affect your bowel function, and also that the combination of radiation and rectal surgery can also affect your bowels, also your bladder, also sexual function. So are there instances where we can avoid some of these treatments and try to reduce toxicity, but not, have a negative impact on cancer outcomes? So I'll talk first about organ preservation, which is what the term we use for trying to maybe defer surgery unless needed. So this is an example. We have studies that showed us that in patients who have a complete response, so you can achieve a complete response to chemotherapy followed by that long course of radiation that I described. Complete response to the best of our abilities to detect that. So based on MRI, based on a good rectal exam, based on a scope going up and looking inside the rectum. And so if we take those patients who had a complete response and watch them closely, what are the outcomes in deferring surgery? This particular study was actually asking that question by just looking at two different sequences of therapy. So we have patients with stage 2 or 3 rectal cancer. Either they had their radiation first and then they went to see Dr. Cecchini and had their 4 months of chemo, or they started with Dr. Cecchini and then came to me. For this stage of patients, and they were probably highly selected as all patients are on a clinical trial, if you looked at them about 8 to 12 weeks after their therapy, in both of those approaches, about 3/4 of them had a complete response, so they could be offered what we call active surveillance. So what is this active surveillance? So it's a lot of poking and prodding, rectal exam and a scope every 4 months for the first 2 years, and then every 6 months. MRI at least twice a year for 2 years, and then annually. What we found was that, or what this study found was that in about half of the patients, it turned out that their tumor didn't recur, that complete response was sustained, and they did not need to have a surgery. And then if you look at how they did and their survival overall compared to what we call historical controls, or just what we know can be expected of patients who received kind of the whole standard treatment paradigm, the survival seemed comparable. And so, from these kinds of studies, what we learn is that we have to be very selective. This requires a certain stage of tumor where we expect a complete response. If we do see that complete response in a patient who is willing to be really actively followed closely, thinking about deferring surgery is an option that we would make as a multidisciplinary team, and really can be applied in select cases, but with obvious benefits. Then I'm going to talk a little bit about what about options where you could maybe not need to use radiation. And so this comes into play for patients that are kind of just meeting the criteria where you would consider radiation. So maybe you have some lymph nodes, but not that many, or maybe there's depth that takes you to the T3 stage, but not the T4 stage. In this study, they were letting those patients have the standard radiation going on to surgery and then chemo afterwards. Or saying, okay, if we give them the chemo first and they look like they're responding, at least a response of 20% by MRI, what happens if we just don't radiate them, go straight to surgery? And in the patients where they didn't seem to respond to chemo, we'll give them the standard radiation. And it turns out most patients, the majority, really like 90% of patients, were responding and had their radiation emitted, and a smaller fraction needed to have the radiation. So really this is saying, can we use chemo first, and then selectively use radiation only for that small fraction that aren't responding to chemo? How does that affect the overall outcome? And the bottom line is there was no difference in local control of the tumor, survival disease-free, or overall survival. Again, a really select group of patients, so this is not for all comers with locally advanced rectal cancer. These are for the lower risk category where your tumor's up higher, maybe a T2 or a T3 with limited or no lymph node involvement. Absolutely, if we're not going to use pelvic radiation, you're going to need Dr. Mongiu to remove the tumor with surgery. Just another scenario where we can kind of tweak the standard treatment course for specific criteria of your particular tumor presentation. And then obviously there are some benefits to not having radiation as part of your treatment course. And I think I'll focus on the long-term benefits, which are really that a year after surgery, if you looked at these patients who did not need radiation, they had lower rates of fatigue and neuropathy, but really better sexual function, and also something that is important, especially with younger population of patients being diagnosed with rectal cancer, better preservation of fertility and ovarian function. So one thing that can happen with pelvic radiation involving the ovaries is that we can induce early menopause in those patients that are premenopausal. So some advantages for sure for being able to avoid pelvic radiation when feasible. And then lastly, I want to talk about how we can be helpful in the scenario of oligometastatic disease. So this is what Dr. Cecchini described as rectal cancer or colorectal cancer, really, that has metastasized, but in a limited fashion. So we have learned that metastasis to up to 5 sites really behaves differently and can be treated more aggressively than colorectal cancer that has spread more diffusely within the body. Oftentimes we remove those limited sites of metastatic disease with surgery, but when surgery is not feasible, we can use radiation, and the type of radiation is slightly different. It's something we call stereotactic body radiation or stereotactic ablative radiation. I always say to my patients, we're just trying to sound cool with all these fancy names. Some people even shorten the stereotactic ablative to SABR. What this means is that we're giving a high dose that we can get away with because the tumor is small, and we're rapidly dropping that dose off right outside of your tumor and taking advantage of technological advances such that we can account for how your tumor is moving. We can precisely localize your tumor for treatment with imaging during treatment, to make sure that we can safely deposit a really high dose of radiation to these small tumors that can have kind of a definitive ablative effect on the tumor. This is one study and an example of how that's beneficial. So this is looking at patients with kind of mixed tumor types. Colorectal was one of them, in that oligometastatic state with up to 5 metastases. And the study asked, well, if we just give them their standard of care chemotherapy, or we add in SBRT to all of the limited metastatic sites, is there a benefit? And the bottom line is the addition of SBRT to the limited oligometastatic sites actually improved progression-free survival and overall survival. So I think the stereotactic radiation, as well as the surgical approach and other local therapies, are increasingly being employed in patients who have limited sites of metastatic disease. And I'll end just with saying that we do have a new program here at Smilow Cancer Hospital, which is one way of treating oligometastatic disease. So this is new technology called the Reflection, which is a PET-directed radiation therapy machine. And it can be advantageous in certain cases. particularly if you have disease that's in the lung. And so I'll explain why that is. So a lung tumor is going to move as you breathe. And for typical stereotactic radiation, we see your tumor, we watch a video, we can get a video CAT scan that shows us how your tumor moves as you breathe. And then we expand the treatment volume to encompass kind of the path your tumor takes as you breathe. With the PET-directed therapy, the treatment machine, you receive an injection of the PET tracer before treatment, and the treatment machine can detect the PET tracer from your tumor. So actually, the radiation field will move with your tumor as your tumor moves during treatment. So rather than expanding the radiation field and treating a bigger area to encompass kind of where the tumor moves as you breathe, we're kind of moving the radiation field with your tumor as it moves, with the benefit being that we don't have to expand and kind of radiate all this healthy tissue around. So like all things, right, there's specific criteria that your tumor would need to meet in order to be eligible for this type of treatment. But I think really an exciting innovation that we have here at Smilow as one modality to try to aggressively treat oligometastatic disease. So I'm going to end there. Little summary, just we know pelvic radiation plays a key role in curative therapy for locally advanced rectal cancer, but we can tweak the radiation based on your tumor characteristics and what your goals of care are. We, in general, prefer the long course daily radiation for 5 weeks, especially for the high risk tumors that are lower down or have deeper involvement of the rectum or lymph node involvement, or if you're thinking about preserving the rectum and not needing surgery. Organ preservation with this active surveillance of MRI and scope can be considered in very select cases if you do achieve a complete response to chemo and radiation. We can think about omitting radiation for certain favorable risk rectal cancer patients that don't have a lot of involvement of lymph nodes or not as deep in the rectum. And finally, we can think about the stereotactic radiation as well as surgery and other local therapies if you have limited metastatic disease. Hopefully, I didn't take up too much time. I'm going to pass the baton to Dr. Mongiu.
Thank you, Dr. Johung. Just to ask one question about radiation is, can you expand a little bit on the side effects of radiation?
So side effects when we're treating the pelvis really are related to the organs that are in the pelvis. And so what we're talking about is bowel and bladder primarily. So when you're in the midst of a course of radiation, you can experience looser stools, frequent stools, diarrhea as a result of radiation. That can be typically controlled with Imodium or other antidiarrheal medications. You can experience frequency of urination from inflammation to the bladder, or maybe a little bit of slight burning with urination, a little bit like a mild urinary tract infection. Most patients tell me that's annoying, but it's tolerable. There's a lot of talk about skin reaction with radiation. If we're treating a higher rectal tumor that's really, kind of within the pelvis, the dose to the skin should be minimal. There may be a little bit of a redness of the skin, but it should be something that is, not barely noticeable. We really worry more about skin reaction when we're dealing with those really low tumors that are coming to the anus. There, we're driving the dose of radiation right to the perianal skin, and that's where redness and skin breakdown there, particularly when you're having diarrhea, can be a little bit more challenging to manage, but temporary and typically heals within 2 to 3 weeks after treatment. Long-term side effects, I touched upon for a younger woman, early menopause, fertility issues. There can be low risk of more severe kind of bowel side effects from inflammation and scar tissue that can develop, so like obstruction of bowel and things like that. But thankfully, those risks are much lower and things that we don't expect to see.
Yeah, there's another question about radiation to the lung, but you answered it during your discussion there. And I'll just answer the one question about KRAS G12D. Yes, Yale has a number of clinical trials focused on tumors with KRAS G12D, including a trial for patients that are receiving their initial treatment for metastatic colorectal cancer, as well as a number of trials for patients that have received prior chemotherapies. And now I'd like to introduce Dr. Anne Mongiu from colorectal surgery.
Hi, thanks everyone. Let me share my screen. All right. So I'm going to talk about a little bit of the plumbing work, and so that's surgical therapy for colon and rectal cancers. Um, So where do I fit in? And we kind of heard everything. Someone, you get a bit taken out, you get a biopsy, so you name it, you stage it with all the imaging, and then we treat it. And finally, you come for rectal cancer, you'll often come to me at the end. For colon cancer, you may come to me at the beginning, depending on what the stage of your cancer is. So it sort of brings us to what's a colectomy? So a colectomy is our surgical term for removing a part of the colon. And so when we think about the colon, I just like to break it down into sort of five parts. So it looks backwards here. The R and the L are for right and left because this is how we're always thinking about things looking at an imaging study. So the colon starts here on the right side. This is the right colon. It goes across the middle. That's the transverse colon. It comes down left side. We call that the left colon or the descending colon. It makes this little S shaped swoop here. This is the sigmoid colon. And finally, down here, you've got the last part, which is the rectum. And we'll talk a little bit more about the rectum a little bit later. So, when we talk about removing the colon, when you've got cancer, well, wherever your cancer is, we're going to remove that part of the colon. So, if it's in the right colon, we're going to remove the right colon. And we do it not only just taking the wall of the colon itself, but then we're going to take the blood vessels, which are behind there, because the blood vessels supply that area and we want to get everything that is feeding that area because we know that around all those blood vessels are your lymph nodes. And the lymph nodes are sort of the first sign of escape. So if you've come to see me and you have an early colon cancer and they've done your CT scan of your chest and your belly and your pelvis, and they didn't see any spread anywhere else. The lungs and the liver and all the other solid organs are clear. We're going to go to the operating room. But what we're going to want to know, and what Dr. Cecchini is going to want to know after surgery is, well, were any of the lymph nodes positive? So when we go and take each of these major blood vessels, so for the right colon, we're going to take this part of the artery right here, and we're going to take in any of the blood supply that feeds this whole area. And we want to get good, healthy tissue around wherever your tumor is. If your tumor is here, we may take a small part of the small intestine and the colon, but we don't want to see it when we're taking it out because we want the tumor to be safely on the inside with good, clean margins on either side. We want to take the blood vessel nice and low or nice and high, basically very close to this big guy in the back, and that's your aorta. And with it, we're going to take all of the fat that's surrounding all those blood vessels in that whole part of the colon. And when we do that, we get all the lymph nodes that are hiding in there. That goes to the pathologist who then actually pick them out one by one, look at each and every one, look to see if there's cancer in those lymph nodes, and then put together a final report that comes about 7 to 10 days after surgery. Okay, there are lots of types of colectomies you can do. And when we're talking about cancer, we tailor it to the blood supply that serves each part of the colon. So I put little asterisks here to give you an idea. These are all different places that you could have a tumor in your colon. And we would look at the appropriate blood supply and then take that part of the colon, always trying to center it. Now, there's a couple down here where you see we're taking out a lot of the colon. And these are some special circumstances. Patients who may have something like inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, who may not only have had this disease for a long-standing period, but now they have presented with a cancer. And in those special circumstances, we often will have to remove most of the colon at that time because the risk to remaining colon is quite high. Okay, so this now is sort of to come back to what Dr. Johung was talking about. Rectal cancer is sort of, we think about it a little bit differently than colon cancer. So when you have a colon cancer, and I'll just go back here for a moment, and we'll just call colon cancer anything that is sort of above this area, anything that's really above this line right here, that's going to be a colon cancer. When we drop into the last 15 centimeters of the large bowel, that's the rectum. And the rectum lives about 2/3 of the way underneath this sort of line here, which is called the peritoneal reflection, which separates it from the main part of the abdominal cavity. The top part of it right here, the top 1/3 is in the regular part of the abdominal cavity with the rest of the colon. And depending on the stage, sometimes we will treat this upper rectal cancer as a colon cancer and operate it on it right away. But when it is below this line, so that's a cancer that would be up here, But once we're talking about a rectal cancer that's below here, that's when you would see both Dr. Cecchini and Dr. Johung well before me to get a full amount of treatment beforehand, like they talked about with the total neoadjuvant therapy. And then we would come in afterwards and take out these tumors. And so, important parts to note here, and this is something that we think about and I'll go with what I'm going to talk about next, but at the very bottom of the rectum, we have what's called the anal canal. And we have these two really important muscles here. And these are called your anal sphincter muscles or your anal sphincter complex. There's an inner muscle and an outer muscle. And we need those to maintain continence or to hold poop on the inside when we don't want it to come out. So as we get lower and lower, we have to think increasingly about, well, where is this tumor in relationship to these muscles? And are we able to get a clean or negative margin beneath this tumor? And so as we get down to right about the top of the muscles, that's about as far as we can go with surgery. And we'll talk a little bit more about the types of surgery in a second. But once we get down here, where you have a tumor that's adenocarcinoma, which is a typical type of colon or rectal cancer, not a skin cancer that's crawled from the outside in. Once we get down here, this usually means that we're unable to save the anus, this bottom part, and the sphincters down there, because in order to get rid of the cancer completely, we'll have to take that out. And so that brings me back to the question I get very often when I sit down with someone. Well, what is a stoma or an ostomy or a bag or a colostomy bag? And am I going to need one? And so ostomy or stoma comes from the Greek and Latin words for mouth, and they've actually been around for a very long time. And it's where we pull a small amount of the colon or the small bowel through the skin, fold it over like a turtleneck, sew it to the skin, and the stool no longer comes out your bottom, but it comes out through this opening and it empties into a little bag that collects the stool. So not everyone is going to need an ostomy bag. In fact, that's really permanent ostomy bags are something that we are really well able to avoid in what we do today. Going back here, looking at this lowest level of tumor, the kind of tumor that's growing within the anal canal that gets its upfront treatment with its total neoadjuvant therapy. If it responds completely, like Dr. Johung was talking about, and there's no tumor remaining and you're up for a lot of prodding and poking, we can often do what's called watch and wait, and you get to avoid me, and we watch it very closely in the clinic over time to make sure that it doesn't grow back, but that does allow some people to preserve their sphincters when otherwise they would not be able to. Forward. All right. Then there's this idea of temporary versus permanent stoma bag. So a lot of times, especially in cases of rectal cancer where you have received upfront treatment, and even though the tumor isn't so low that we can't get it out, we can still save the sphincter muscles because that tissue is a little bit, we'll say, jeopardized by the fact that it's had the radiation, the chemotherapy. It makes its healing potential in the moment a little bit lower. And what we know is when you're trying to bring two ends of the colon together after you've taken out the segment containing the tumor, it's very important that it heals absolutely perfectly so you don't get what's called a leak. We know that when you've been radiated, that oftentimes that risk of leakage goes up substantially. And so for many patients who have rectal cancer who get full treatment beforehand, we make what's called a temporary stoma. And temporary in our world is 4 to 6 weeks. We do a little leak test at the 6-week mark, and then we close the stoma right after that. And so really at this point in time, there are very few patients that we have that require a permanent stoma. It's really those with a tumor that doesn't respond to treatment, that's very low down and well within the anal canal involving the anal sphincters. All right, so how do we do colon surgery today? This is the photo that hung on the wall where I trained in Boston, and this is a picture of the first surgery that was ever done under anesthesia, and this was at the Mass General. So people really literally sat around in the stadiums and watched, and it was done open, and they didn't have scrubs. We continued to do open surgery for a really long time, but by the time we got to the 1980s, laparoscopic surgery had really come into being. As you can see, you had sort of an old screen and people holding these long, skinny instruments on sticks with a camera and tiny instruments. And this is called laparoscopic surgery. We still do a lot of laparoscopic surgery today. It usually involves at least two people because you need an extra pair of hands because we currently only have two hands, and someone's got to hold a camera, and you need at least two working hands to do an operation to take out a part of the colon. Um, More recently, and stuff that you may have heard of or seen on TV, but within the last 20 years, we've gone on to robotic surgery. This is a picture of the intuitive Da Vinci robotic system, and that's what we use at Yale. In fact, actually, this is the last version of it, and we have actually upgraded our entire system to the DV5 intuitive system, which is the newest robot that's on the market. And so I would say we have probably one of the largest robotic programs in the Northeast just by the sheer number of robots that we have here at Yale. And robotic surgery is kind of fun. It's also really interesting. So, what you're looking at in this picture is the patient would be here laying on the table, and this is the intuitive surgical robot. It has four arms that can be controlled by one person. So, you have a camera, which is right here, and you've got three operating arms. There's always someone at the bedside because you have to exchange the instruments manually, and it uses the exact same kind of ports that you use when you're doing laparoscopic surgery, but instead they have a little adapter on them that clips into the robotic arms. The instruments themselves from a distance appear very similar. We have scissors, we have graspers, we have really nice cameras, but what's really great about the robotic instruments is that they're what we call wristed. So a typical laparoscopic scissors, like a scissors, like you cut with, is straight. It can cut in one plane. It's on a stick, so you can move it up and down, up and down. And that's how you can cut or divide the tissue that you need to divide to take out a part of the colon. When it comes to robotic surgery, it has an actual wrist and it has more degrees of freedom or more ability to rotate on an axis than the human wrist does. And all of the instruments that the robot uses are the same way. And the camera is actually not a single camera, it's two high resolution cameras within one camera body, which means when you're looking through the console, which is about 5 feet away from the patient, you actually are in a 3D viewer headset. So everything that you see is in 3 dimensions, and the magnification is much higher than it would be. And there's no glare coming off of a flat screen like you would in laparoscopy, but you're actually seeing in 3 dimensions. Another area when it comes to colon surgery that's of particular interest is the fact that the robot also has a near infrared light source or laser built into it. And that can excite certain injectable chemicals to allow us to see where there is blood supply. Like we talked about in the very beginning, the blood supply to each part of the colon determines where we're going to take it out and how we decide how much of the colon around the tumor we're going to take out. In this case, when we get ready to divide the tumor and we want the tumor to be in the area of the colon that's coming out, and we've taken away the blood supply there, but we want to make sure that new connection that we make is going to be healthy enough so that when we bring the ends together, they heal. We'll inject this green, this liquid. It's called indocyanine green, and we inject it in. It actually lights up all the blood vessels. So you can see this area here is really bright green, and that corresponds to the same part of the colon right here. It tells us it's got great perfusion. But the part where the tumor is, this is the back end of the upper part of the tattoo here on this side. It all looks the same. It all looks pink. But when we look here, you see it's not very green. And that tells us that this area doesn't have good blood supply. So we know when we're going to cut the tumor out, we're going to cut right here into the healthy green area. And that's the area that has a good blood supply that we're going to use to make that connection. So that's another benefit. This is just a little bit about what does the data actually show for robotic surgery compared to more old-fashioned surgery, which is open surgery, a lot shorter hospital stays, return to normal activity, and wound complication rates. It has been pitted together, especially in colon and rectal surgery in particular, head to head with laparoscopic surgery along a number of different clinical trials. And robotic surgery has been equally efficacious with the same cancer outcomes, but other quality of life outcomes, such as sexual function, are actually better in robotic surgery. And that's thought to be due to the extreme stability and precision of the viewing platform with the 3D viewing, which allows us to spare a lot of the nerves, which sometimes you just can't see with laparoscopic surgery. All right, so that's a little bit about the nuts and bolts. And without cutting too much into what Mike talked about, I just wanted to mention one thing that's near and dear to my heart with just a couple slides as we wrap up. What's new? I don't think you can avoid the news. It's a shame with the passing of Mr. Vanderbeek, but colon cancer is rising in young people. It's now the number one cancer killer among adults under 50. It's increased twofold in adults under 50 since the 1990s. And now 1 in 5 new colon cancers will be under the age of 55. And oftentimes we're seeing young people present with really advanced stage disease. And this is because we've went from a screening age of 50, and in 2021, we rolled it back to 45. But even still, we're catching people younger than that because we're not screening people in their 30s. I get asked this a lot in my clinic, and why are more young people getting colon cancer? And the real honest answer is we don't have a very good answer to that question. There are a lot of factors that are probably involved in this. That includes the diet and your food environment. We know that there's a rising rate of obesity, type 2 diabetes, and metabolic syndrome. And we know that there's actually very good data that sugary beverage consumption between the ages of 13 and 18 and obesity in that age range predicts later obesity driven cancers, of which colon cancer is one of them. We know that our food environment changes the natural healthy bacteria that live in our gut. And we know that changes in those bacteria can lead to more inflammatory states, which can promote carcinogenesis. And again, we talked about genetics as well earlier. I wanted to talk about one last area that's sort of new to what we're doing at Yale, and something that is part of our Loving Your Guts and Food is Medicine campaign, which is understanding how your zip code affects your cancer risk, how food environment is involved in carcinogenesis. And one of the things that we know is there are areas that don't have good food supply, whether it's access to healthy food or being surrounded by a preponderance of unhealthy food, which is what a food swamp is. And we know that this can have an impact on early onset colorectal cancer and its outcomes. We have been doing a lot of research on this by mapping out everything in the entire state of Connecticut. And what we have found in our original Yale data, where we mapped everyone at Yale, was that certainly we saw worse cancer outcomes in our early onset cancer patients who lived in unhealthier food environments. And more recently, as we expanded this to go to the entire state of Connecticut with the assistance of the Connecticut Tumor Registry, what we're seeing in the state of Connecticut is actually a significant survival difference in our youngest patients with cancer who live in unhealthy food environments. And so I say this as we keep talking about finding healthy foods to eat, but this is something that there are a lot of modifiable risk factors that people can look forward to. And as part of our Yale Teaching Kitchen, we've been trying to work on having healthy eating teaching kitchen video webinars that can talk about how you can cook healthy, high fiber meals for good colon health for under $4 to $5 per serving. And so this is something that we've been really working on over the last year and a half. I want to say thank you to everyone for coming tonight. I'll stop my share and I'm happy to take any questions.
Thank you, Dr. Mongiu. I think we're at time, and the questions have been answered in the chat as they came available. So thank you all for your attention this evening. As noted previously and in the chat, this will be posted online, and a link will be sent out to anybody that registered for the event. Thank you again, and thank you to my co-panelists here. Have a great night.